Hello, good evening. Welcome to this evening's program, Our Wakanda Colorectal Cancer in Younger Adults, hosted by the Meyer Cancer Center, Office of Community Outreach and Engagement. My name is Kelly Jack, and I'm the program manager for the office. March is Colorectal Cancer Awareness Month, and with the untimely passing of Chadwick Boseman, it was important for us to bring awareness to the disease in younger adults, who unfortunately, the actor Black Panther passed away at the age of 42. While still relatively rare among younger adults, colorectal cancer is rising among this population, which will be addressed by our presenters. At the end of the evening, we will also have a panel discussion to answer questions that arise during the presentations. So certainly use your Q&A function at the bottom of your screens for any questions throughout the evening. And if you're viewing us on YouTube, use the chat box at the right of your screen if you are viewing on a computer or laptop. You will not be able to turn on your cameras or unmute yourselves throughout the webinar. Some other housekeeping items. While we encourage you to ask questions, we may not get to questions that are specific to your medical condition. Instead, we encourage you to consult with your primary care physician, especially if you're experiencing any symptoms. And if you are in need of a primary care physician, please send a message to the panelists on the Q&A, or again on YouTube, just drop something into the chat box there. We will also share resources throughout the evening, including how to obtain a free stool-based screening test through our office. And you'll also learn more about that test if you haven't heard about it already. Before we begin, I just have to say that this webinar is supported from funds from Health Research Incorporated and the New York State Department of Health, with funds from the CDC, also known as the Centers for Disease Control and Prevention. Thank you so much. And without further ado, I would like to introduce Assemblymember Jaime Williams of Assembly District 59 of Brooklyn, who will start us off. Thank you.
Hi, everyone. My name is Jaime Williams. I'm the Assembly member for the 59th Assembly District, which encompasses of Canarsie, Flatlands, Georgetown, Bergen Beach, Mill Basin, Marine Park, Garrettson Beach, and Floyd Bennett Field. As we embark on the month of March, we are bringing awareness to you in regards to Colorectal Cancer Awareness Month. Colorectal cancer is the second leading cause of cancer death in New York City, after lung cancer. In Brooklyn, Canarsie has the 5th highest colorectal cancer death rate. It's important for me today to speak to you all, especially my fellow Brooklynites and constituents, about the importance of colorectal cancer screening, because the earlier cancer is detected, the earlier you can treat it. Tonight, you're going to hear about the importance of colonoscopies and a stool-based test, also known as a fecal immunochemical test or FIT test. You will also learn ways in which to reduce your risk of developing the disease. If you have ever gotten a colonoscopy, please tell the audience or share your experience. Any policy initiatives related to this chronic disease or any healthy behaviors that you would like to share. I encourage you all to live a healthy life to prevent the development of cancer or any such chronic diseases. Thank you.
Thank you, Assemblymember Jaime Williams. And I would like to also take the time just to thank also Senator Roxanne Prasad of New York State Senate District 19, who's also joining us this evening. As you heard Assemblymember Jaime Williams state that not all neighborhoods are affected the same by colorectal cancer. And it's important for us to bring awareness to that fact. So next up, we have Dr. Jennifer Brown, who's the Assistant Director of Cancer Prevention and Control Program with the Bureau of Chronic Disease Prevention in our city's health department. Thanks to efforts by the health department, screening rates for colon cancer reached 69% in 2018, up from 42% in 2003. So yay, New York. Dr. Brown will now speak about the city's recommendations to reduce the screening age from 50 to 45 for individuals who have an average risk of developing colorectal cancer, as well as the Community Cares Project. Thank you, Dr. Brown.
Thank you to the organizers for inviting me to speak about screening for colon cancer at younger ages in New York City. I'm going to give some background and then talk about updating the New York City screening guidelines and share some resources and talk about Community Cares Project. Let's first look at colon cancer screening in New York City. You can prevent colon cancer or find it early when it's easier to treat by routine screenings with a colonoscopy or a stool-based test. This map of New York City shows colonoscopy rates by neighborhood, and they vary from 58% to 84%, shown in blue, with darker blue representing lower screening rates. No significant differences in screening rates are seen between races and ethnicities in New York City. However, Manhattan residents had higher colonoscopy rates than in the Bronx, Staten Island, Queens, and Brooklyn. Screening for colon cancer also varies by age. People in younger age groups get screened less than older people. About 1/4 of people ages 45 to 49 are screened by colonoscopy, in comparison to about half of 50 to 54-year-olds and about 3/4 of people who are ages 60 and older. Increasing screening in younger people would potentially save more lives from colon cancer. In March 2020, the Health Department revised our colon cancer screening recommendations. Our goals were to reach 80% screened in every community, lower the burden of colon cancer, and reduce disparities. During the pandemic, colonoscopy was less available. COVID-19 testing was required beforehand, and some patients had an increased fear of going to hospitals for procedures like colonoscopy. The new recommendations help address some of these barriers. With guidance from the C5 Screening Guidelines Committee, the Health Department recommends to consider screening at age 45 for average risk individuals as opposed to previously age 50, with options including a colonoscopy every 10 years or yearly stool-based test. And all positive stool-based test results must be followed up with a colonoscopy. People at increased risk may need to be screened before age 45. National organizations like the United States Preventive Services Task Force are updating their guidelines, now in draft form, also to begin screening at age 45. Why the age change? To save more lives through earlier colon cancer detection and prevention. This can lower the colon cancer burden in New York City. An increase in colon cancer at younger ages has been reported across the nation. Data on the slide shows colon cancer incidence has been increasing since about 1990 in New York City, overall for people aged 20 to 49. There was a particularly strong trend among Black New Yorkers. Colon cancer incidence has been increasing at 1.5% each year overall in this age group. And remember, their screening rates are lower than for people ages 50 and older. Racial ethnic groups in New York City had inequities in death rates from colon cancer shown here. Black New Yorkers have a significantly higher rate of death from colon cancer overall and at younger ages, shown here in the orange bars. From the latest 5 years of data, at 45 to 64 years old, colon cancer death rate for Black New Yorkers was nearly double that of white, Latino, and Asian New Yorkers. The new policy of screening at younger ages is intended to reduce the existing known racial inequities by screening more people at younger ages when colon cancer death disproportionately affects Black New Yorkers. Why a choice of tests? Ideally, having a choice will increase screening. Evidence supports that some New York City groups prefer stool-based tests over colonoscopy, and having a choice makes it more likely you'll complete the test. It also helps address barriers to colonoscopy, and choice may lessen disparities in screening. The health department has resources available for you about colon cancer prevention. The Get Screened brochure provides information on steps to colon cancer screening, questions to ask your provider, and no-cost and low-cost screening locations. We also have fact sheets to help patients communicate better with their healthcare providers when comparing the different colon cancer screening tests. These are available in 14 languages. The colon cancer screening form is a screener for patients to complete before they talk with their healthcare provider about when to be screened and which tests to use. These can be completed by a patient before the visit. Links to these materials will be provided. You can also find these materials on our website by visiting nyc.gov/health and searching for colon cancer. Or you can request copies by calling 311. Interventions are needed to help people without health insurance to get a timely colonoscopy screening for cancer prevention. Community Cares Project, established in 2013 by the Health Department, is one such intervention. It aims to reduce inequity between the insured and the uninsured. It links uninsured New Yorkers from community health centers to participating endoscopy centers for free colonoscopy, anesthesia, and pathology. Community Cares Project serves 700 to 800 uninsured New Yorkers every year. From 2013 to today, 4,655 patients without insurance have been screened for free through Community Cares Project. The Community Cares Project partners include 17 primary care health networks and 31 different clinical sites, including 8 H&H sites. And they partner with 11 endoscopy centers to provide the free colonoscopies. In summary, all New Yorkers should, starting at age 45, ask your healthcare provider about the benefits and risks of colon cancer screening. Know your risk. You may need screening before age 45 if you have high risks, such as colon cancer in your family. Get covered. If you don't have insurance, you may be eligible to sign up for low or no cost insurance through Get Covered New York. You can call 311 or text Covered NYC to 877-877. New Yorkers who have no insurance may be eligible for low or no cost screening. And to learn more, you can visit nyc.gov/health and search for colon cancer. Thank you.
Well, thank you, Dr. Brown, for all your work that you do in the Department of Health and getting people, knowledgeable of the screening guidelines, the change of the screening guidelines, as well as connecting uninsured eligible individuals with screening. I think that, that's especially important during this time. And some of the resources that she shared will also be shared in the chat, so you all can take a look and advocate for your health. It's very important that you take this knowledge and go back to your doctor if you're not having these conversations and say, hey, doc, why am I not getting screened? I'm 45 already. Or why haven't you suggested I get screened? Jennifer, she did talk about different methods of screening. And now we will segue that into our next speaker or his presentation. So Dr. Carl Crawford is a gastroenterologist here at New York-Presbyterian, Weill Cornell Medicine. Dr. Crawford will talk to us about screening methods for colorectal cancer.
So today I'll be talking about colorectal cancer in younger adults. And in 15 minutes, I'll try to talk about statistics on colorectal cancer, symptoms of colorectal cancer, the effective screening methods for detection and prevention of colorectal cancer, and a personal encounter with colorectal cancer. Now, just to start with some simple facts, colorectal cancer is the third most common cancer in the United States. It is also the second most common cause of cancer deaths among men and women in the United States. Of note, African-American men and women are 20% more likely to be diagnosed with colorectal cancer at an earlier age. And it's more aggressive when it's diagnosed, it's harder to treat when found, and African-American men and women are 40% more likely to die from colorectal cancer than almost any other race. Screening now begins at 45, not the age of 50, or sometimes sooner if symptoms occur, if the patient has certain personal or family history of colon lesions or diseases. Now, the symptoms of colorectal cancer can vary, and sometimes they're very nondescript. Sometimes a person may develop a change in bowel habits, and that just means either the development of new onset diarrhea or constipation, or even a change in the caliber or the size of the stool. Some people may present with abdominal pain or cramps or discomfort inside of the abdomen or the belly area, and they may even have some trouble evacuating or having a bowel movement. As a colon cancer progresses, sometimes a patient may have more other constitutional symptoms, such as unexplained weight loss or weakness or fatigue. And on routine testing at your doctor's office, your doctor may notice that your iron levels in the bloodstream are low or that your blood count is low. When colorectal cancers become more advanced, people may notice some blood in the stool, which may be bright red or different colors, such as black or maroon. And they may even notice that there is the involuntary passage of blood into the toilet bowl itself. Now, one of the most common symptoms of colorectal cancer when it's at its earliest stage is no symptoms at all. And that's the scary part of colorectal cancer, because it may be present in your system without you even knowing it, or even the early stages of a cancer may be present without you having any of these symptoms. So if that's the case, how do you know when to get screened or to look for colorectal cancer? Now, to take all of the guessing out of this, everyone should be screened at the age of 45, and these are based on the newest recommendations. African Americans were advised to receive their colonoscopies before the age of 50, and that was several years ago. But as we looked more and more into this, we realized that the entire population is developing colon cancer at an earlier age. Sometimes patients may need a colonoscopy or a screening test sooner than the age of 45, and usually these people may either have a family history of colorectal cancer or colon polyps. They themselves may have a personal history of colorectal cancer or colon polyps. They may have a personal history of inflammatory bowel disease, such as ulcerative colitis or Crohn's disease. They may have a known or suspected family history of a colon polyp or a cancer syndrome. Also, anyone that's had radiation to the abdomen for cancer treatment should also be screened at an earlier age. Now, if we're screening patients for colorectal cancer, then what are these different tests? And the Multi-Society Task Force on Colorectal Cancer recommends 3 big groups for screening. They call them Tier 1, Tier 2, and Tier 3, with Tier 1 being the most effective screening modalities and Tier 3 not being as good. So for Tier 1, there's colonoscopy and fecal immunohistochemical tests, and I'll talk about these in a little bit. Tier 2, there's a CT colonography, a Cologuard, and a flexible sigmoidoscopy. And Tier 3 are capsule endoscopy, and unfortunately, there is no blood test yet, although they are in development. So let's talk about colonoscopy. Colonoscopy is the gold standard for both the prevention as well as the detection of colorectal cancer. The pros of having a colonoscopy are that they can be repeated 10 years if everything is normal. And of course, if someone does detect a polyp, you would need to have a procedure sooner than that. Now, the cons against a colonoscopy would be that it does require some time. One has to take a preparation where you drink a liquid that flushes or cleanses the gut of all fecal material. It is a procedure, which means that patients are sometimes sedated for this. And there are risks with using an invasive test, such as risks for infection, bleeding, tears in any of the parts of the bowel that we work in, or having reactions to the medications that we give you to make you sleepy. However, all of those risks are extremely low. They're less than 1%. But in life, nothing is ever absolutely zero. On the bottom, you see a picture of what a colonoscopy looks like. A flexible camera is actually inserted into the rectum. And at the tip of that camera, there's these channels that one can use in order to remove a polyp if necessary. This camera goes through the entire length of the large intestine, and gives us a very good look as to the health of the colon. And I'll show you a couple pictures. So the colonoscopy is considered the gold standard because we can view the inside of the colon in high definition. And that's what we see here. If we see anything that looks irregular, and here you can see a small little growth in the center of the screen, and that's a polyp. And as you can imagine, if the colon is the length of your height, and there is a small lesion that's only the size of 2 to 3 millimeters, one may not have any symptoms at all. The beauty of a colonoscopy is that these small lesions can be detected and removed at the time of the procedure. Nothing hurts during the procedure or even afterwards when one wakes up because of the medicines that we use to help you fall asleep for the procedure. The entire length of the test is usually less than an hour, and it can be as fast as 15 minutes depending on the quality of the prep that you drank. Now, one of the reasons to remove these small little lesions, even though they may not give you any symptoms at all, is that they can continue to grow. And when they continue to grow, they can become larger than life. And sometimes they can become a cancer. And here we can see a picture of what is an abnormal growth inside of the colon. And this is a colorectal cancer. Eventually, that small little polyp that you see on the left can grow into something as large as what we see on the right. And that can eventually erode into the wall of the colon and get into the bloodstream and go into other parts of the body. So the goal of the colonoscopy is to bring a patient in before that large lesion develops. As a gastroenterologist, I look for these small little lesions and remove them at the time of colonoscopies. And that is the best way to prevent colon cancer. Now, there are some other tests. So I mentioned before that there are a stool-based test known as FIT, or fecal immunohistochemical test, but it's easier just to say it's a stool-based test. And these tests actually detect unseen, or what's called occult blood in the stool. And the pros for this are pretty simple. It's an easy test that one can do at home. And once the test is done, you can just mail it into the office. Or sometimes you can have this test done in your doctor's office at the time that you're seeing him or her. Now, these tests are easy to use. Basically, it's a small little card. You open up the card, you take a small little brush, and then you paint a small smear of stool on, these little slots, called A and B. And then what will happen is you will send this off to the lab, and the lab will put a small little chemical on top of the small patches. And if there is a reaction, it turns blue. And the doctor will then know that there is evidence of bleeding inside of the colon. Now, the cons of this test are that you do have to have blood in the stool in order for it to become positive. And the issue with that is that sometimes you can have blood in the stool for other reasons like hemorrhoids. So if the test comes back positive, one has to be concerned, well, is it really a colon cancer? Or could it be something as benign as a hemorrhoid? And one doesn't know at that time. Sometimes these tests may not detect a small little polyp. It may not detect a big polyp because it hasn't bled as yet. So sometimes these tests can be falsely negative. As a result, these tests do need to be done yearly. And if they're ever positive, the reflex is to follow up with a colonoscopy. There are stool-based tests that are slightly different from that one. And these are the DNA tests. And you may have seen some commercials for what's called Cologuard on the TV over the last year or two, especially during the pandemic, because this test looks at stool and it looks for, in particular, abnormal DNA from small polyps or advanced lesions or even blood. And the pros for this test are that it is a simple and convenient thing that one can do at home. You do have to use a container. It is slightly cumbersome, but once you have a bowel movement in these containers, there's a nice packaging that goes with it, and you mail it back to the lab. And the lab will then analyze the stool and see if there's any evidence for advanced lesions or colorectal cancer. So the drawbacks of this test is that it does detect blood. I mean, just like with the FIT test, if there's blood in the stool for another reason, such as hemorrhoids, that test can become positive. Also, these tests look for abnormal DNA, which means that there are only certain kinds of abnormal DNA strands that they're looking for. And if you're an individual that has a different DNA strand that's not within their test, you can have a missed lesion. As a result, these tests do need to be done every 3 years. And if they ever become positive, the reflex is to have a colonoscopy. The next test is a virtual colonoscopy, and this is a specialized CT scan to detect surface irregularities inside of the colon itself. The pros are that it's a non-invasive test. However, there are some drawbacks. One still needs to prepare as if they were having a colonoscopy, which means that you have to drink a prep that flushes everything out of the system. You are given an enema at the time of the procedure. This enema is under pressure and it delivers contrast inside of the colon in order to highlight the walls of the bowel. There is no sedation, which means that it can be slightly uncomfortable because you are awake. And the test is a CT scan, which means that they do use small amounts of radiation in order to highlight the bowel. These tests need to be repeated every 5 years or so. And of course, if there's anything that's detected, then you need a colonoscopy. One of the other drawbacks, however, is that we're still not certain if this test is able to pick up flat lesions inside of the colon or smaller lesions that are the size of 1 millimeter to 2 millimeters. I mentioned some other tests. A flexible sigmoidoscopy is a tier 2 test. It's supposed to be repeated every 5 to 10 years, but the problem with a flexible sigmoidoscopy is that it's really just half of a colonoscopy. It's done without sedation. It does require a prep. So there's the same risks as a colonoscopy minus the sedation, so it's a little bit uncomfortable. And you can compare it to having a mammogram of just one breast. It's not a complete exam. There still is a whole other side of the patient that still needs to be evaluated. And the drawback of a flex sig, of course, is that a right-sided lesion will be missed. A capsule endoscopy is a tier 3 test. It's still under development and we're still researching this modality, but this just requires a patient to prepare for a colonoscopy, but instead of an invasive procedure or the need for any kind of sedation, the patient just swallows a little camera pill. And this camera pill will take pictures as it tumbles throughout the entire gastrointestinal tract, and a gastroenterologist or the medical professional will then go back through all of the images and look to see if there's anything that's abnormal or unusual that's detected. If any of these tests come back, positive for the flexible sigmoidoscopy, for instance, you can remove something at that time, but it does leave the right colon unseen. For capsule endoscopy, if something is detected, you can't remove it at that time. So it means that you have to come in for either a flexible sigmoidoscopy or even a colonoscopy to have that lesion removed. Currently, there are blood tests that are being developed, but they're not good enough for us to deploy in the real world. Now, I just want to end with just talking about colorectal cancer as a familial disease. And sometimes when we hear the word familial, we think about genetics, but colorectal cancer actually affects the entire family. It's not just the individual patient. So if you look at this picture here, you may notice the person on the right side. At this point, they would call him Cassius Clay, but we know him as Muhammad Ali. And on the left is actually my dad, who was a light heavyweight boxer that represented Guyana in South America. And this picture was taken during the 1960 Olympic Games in Rome when they were both sparring partners. And I always looked up to my dad as, my hero. He was an imposing figure, but had one of the warmest hearts you would ever encounter. So that was, my dad. We never thought that he could ever get sick, and I actually never ever saw him sick. And I'll just take you through a small timeline. In 1983, that's me and my dad. I don't even remember where we are. I just hung on to his coattails wherever he went. In 1991, I was in high school. I got back late. This was my birthday. They stayed up, and my mom and my dad waited for me. And around this time, my dad actually started having symptoms of blood in the stool. And he had told his doctor that he had some bleeding. The doctor told him that no tests were needed. It was most likely hemorrhoids. My dad was then diagnosed with colorectal cancer in the summer of 1994. In 1996, this was my first day in medical school at Yale. And, my dad had undergone several rounds of chemotherapy. as well as multiple surgeries, but he was able to see me in medical school. In 1998, this is a picture of my family. Here you can see my dad, he's the tall one. I'm on the far right. My two little brothers are down in the middle. That's the youngest one kissing my mom, and my sister's in the back. I don't have a picture of the year 2000 because my dad passed away from colorectal cancer in 1999. So colorectal cancer does not discriminate. It doesn't care if you're a hero. It doesn't care if you're the Black Panther. It doesn't care if you're Chadwick Boseman. It doesn't care who you are. It's one of the few things that does not discriminate. The easiest way to beat colorectal cancer is to prevent it. And with the test that I mentioned earlier, that is the best chance that all of us have at not developing colorectal cancer. So the take-home messages are that colorectal cancer disproportionately affects African Americans. It starts at a younger age, it's more aggressive, and it's harder to treat in this group. Screening starts at the age of 45 unless there's a family history. If there is a family history, then start at the age of 40 or 10 years sooner than the age that person was diagnosed or whatever is the youngest age. Of course, if a patient has symptoms, if there's any change in bowel habits, blood in the stool, unexpected weight loss, iron deficiency, anemia, you don't wait until the age of 45. You see your physician and you have a screening test right away. Colonoscopy is the gold standard for colorectal cancer screening and prevention. There are some other options for screening, such as stool-based tests and imaging, but we have to see what best works for you. Like I said before, colorectal cancer discriminates, but the tests don't. The tests do not discriminate. Anyone can have any of these tests, because at the end of the day, any screening test is better than no test.
Thank you so much, Dr. Crawford. Thank you for bringing to attention or reinforcing some of the topics that we heard from our previous speakers, the racial disparities of colorectal cancer, the importance of screening at 45. Thank you for providing us such a deep overview of the different types of colorectal cancer. And most importantly, thank you for sharing such an impactful and powerful story about your father. I know it's never easy talking about the loss of a loved one, and I sincerely thank you for doing that. During this time, during COVID, I know that some of us are a little scared to get into doctors' offices and to clinic spaces, and it's important that we understand that cancer hasn't stopped during this time, and we need to continue to prevent, to screen, as early detection saves lives. There are certainly things that we can do now to decrease some of our chances of developing colorectal cancer. And now I will introduce our next speaker who will speak a little bit more on this topic. Dr. Yo is a colorectal surgeon here at New York-Presbyterian Weill Cornell Medicine. And Dr. Yo will talk to us about changes we can make today to reduce our risk of developing colorectal cancer. Thank you.
Hello, my name is Heather Yo. I'm a colorectal surgeon at Weill Cornell NYP. I'm really excited to be here today to talk to you during Colorectal Cancer Awareness Month about colon cancer basics. I'm going to talk to you about some of the risk factors for colon cancer and also about how things that you can do to improve your health and decrease your risk for colon cancer. So colorectal cancer is one of the most common cancers in the world. It's actually in the United States, the third most common cause of cancer in men and women, and it's the second most common cause of cancer death. We know and we understand that as countries have industrialized, as we become more westernized, there are higher risks of colorectal cancer. And as the diet changes and as food becomes more processed, people and individuals have a higher risk of colon cancer. If you look at a global scale, you'll see here where it's red, that's where the highest risk of colon cancer, both coming down with colon cancer and of having death from colon cancer, come in the dark red or dark blue spots. One thing that's most concerning to us in the United States is that African Americans have the highest incidence, meaning the most number of cases of colon cancer, and the highest rate of dying from colon cancer in the United States. In fact, their risk of dying is 20% higher than their white counterparts. And in fact, they have a higher incidence of having the colon cancer under the age of 50 and are more likely to present with advanced disease. In fact, because of this, national guidelines have recommended screening African Americans and underrepresented minorities at a higher rate than their white counterparts and at an earlier age. But we know that there are disparities in screening, treatment, and in fact in family history. One thing we know is that African Americans, unfortunately, are more likely to die from colon cancer. And so, as I mentioned, we start screening earlier and try and make sure that we reach out to those that don't know this risk. Because many individuals, in fact, 1/3 of the individuals who are at risk are not getting the proper testing. We are concerned because African Americans are diagnosed at younger age. And as a result, we are having to see at more advanced stage and lower rates of survival. So if you look, and I know that this is a kind of fancy figure and graph, but the highest all of this shows is the risk of having colon cancer by race. And you see at the very top, the most common, the highest is non-Hispanic Black men. And so that's important for us to consider. When we look at the gender, colon cancer is similar in both genders, but it has a slightly higher rate in men. So it's even more important that we make sure that both men and women are properly screened. Looking at these numbers on this figure here, men are in blue and women are in red. And this just tells us again that the rates are higher as you get older, although there's an increasing incidence in young individuals and it's higher for men. So how can we figure out ways to help individuals? Colon cancer happens. It's a result of both genetic factors, so risk factors that we're born with, and environmental factors, so factors that we face every day in our lives, on our health and our diet. But it's estimated that about half of colon cancers might be preventable through dietary and lifestyle changes. So you may have heard, and one of my colleagues is going to talk a little bit more about screening. We screen with colonoscopy. The reason is because colon cancers start as polyps. And in fact, we believe that a small little polyp grows, and as it grows over time from just a kind of excess proliferation of cells, as it encounters more and more environmental toxins in conjunction with some of our genetic components, it converts to a cancer. This transformation from a polyp to cancer takes somewhere between 5 to 10 years. So we have a chance to slow it down by modifying our dietary factors and some of our other health and environmental factors that we expose ourselves to. So there are a number of dietary factors that are implicated in colon cancer, and I'm going to talk about each one of these. The most common thing, or one of the things that we know well, is that the more red meat you eat, the higher risk you have of colon cancer. The more animal and saturated fats we eat, the higher risk of colon cancer. And then the more sugars we're exposed to also puts us at increasing risk. And as we know from some literature, alcohol is also at higher rates. It's implicated in multiple cancers, and that's including colon cancer. So I'm going to start by talking about red meat. Constant daily consumption of red meat is definitely been shown to increase your colon cancer risk. And in fact, studies have shown that you have about a 17% increase in colon cancer for every 100 grams of red meat you have per day. And in fact, any processed meats increase your risk by about 18%. In fact, the World Health Organization has classified processed meat as a carcinogen, and it's important for us to think this. I don't think that anyone expects people to cut meat out of their diet entirely, but just know that larger amounts of red meat, particularly processed meats, put us at risk for colon cancer. As I mentioned, Sugar has increasingly been known to cause and help cancers proliferate. And in fact, when looking in the lab at rats that are totally normal, if you give them high fructose corn syrup, they have a higher rate of cancer formation. And in observational studies of people, we see that that happens as well, even in absence of being overweight. As mentioned, we know that alcohol consumption increases your risk. So moderate consumption, 1 to 4 drinks a day, is only associated with about a 15 to 20% risk, but heavier drinking increases your risk by over 50%. In addition, as is concerning with the younger age of onset we're seeing in individuals, is that alcohol is also associated with a much younger age of onset. So, as I mentioned, we can cut some things out of our diet, but there are actually things that we can do to decrease our risk of colon cancer proactively. So what are the things that we know might be protective? We know that diets high in fiber, high in antioxidants, for example, folate and B12 and vitamin D, are all protective against colon cancer. We know that fiber, just 10 grams a day, so that's probably like 2 bowls of a high fiber cereal, is associated with about a 10% reduction in colon cancer risk. And these differences are highest in grain fibers, for example, cereal fibers, and whole grain are best, even better than fruit and vegetable fibers. There are a number of different ways that we think this works. One is that by eating fiber, things move through your colon a little bit faster, and so it may help with the toxin exposure. In addition, fiber helps to work with other supplements to help protect your colon. Other lifestyle factors that we know about that increase colon cancer, we know that obesity increases the risk of colon cancer, that exercise decreases the risk, and that smoking increases your risk. So unfortunately, obesity increases the risk of colon cancer, but it also influences the outcomes of patients that have it. This link is strongest in men and also in women who have not who are not postmenopausal. There are many medical options and surgical options to manage weight, and these treatments have been shown to actually decrease your risk of colon cancer. So we know that exercise and physical activity decreases your risk of colon cancer. And this happens for a number of reasons. Number one, your body's overall healthier and able to process toxins in a better way. And just like fiber, it actually increases the way that food moves through your intestine. So it's less likely that toxic products are going to spend time in your intestine. Now, I think most of us know that unfortunately, tobacco increases multiple different types of cancer, and many colon cancer is no different. Multiple studies have shown that, that smoking increases your risk not only of getting colon cancer, but of not doing well after a colon cancer diagnosis. People who smoke are more likely to have early, younger colon cancers and more likely to have colon polyps. So what do we do about our risks besides the general health and wellness we just talked about, making sure that you eat well, that you exercise, that you minimize red meat, that you make sure you get enough fiber? I think that it's important to screen. My colleague, Dr. Carl Crawford, will be talking to you about the importance of screening. And I think that driving awareness is the reason we're here today, because if they are found early, colon cancers are preventable. So thank you very much for your time. And we are happy to take your questions at the end of the panel.
Thank you so much, Dr. Yo. I think it's just important to note that there are certain things that we can do now. And when we look at race and hearing that Black Americans are disproportionately affected by colorectal cancer as well as other diseases, unfortunately, well, not unfortunately, but we can't change our race. And for that, we do know that there are other health system issues in place that aren't solely on those who are Black. And that's a whole nother topic and discussion for another day. When we think of things that we can do now, such as Dr. Yo mentioned, as decreasing our consumption of red meat, as decreasing our intake of alcohol, as making sure that we're getting physical activity in, it's important to say that, this is not just for colorectal cancer, this is for other diseases as well. This helps improve our heart health. It helps improve other types of cancer health. So I think that it's always important to keep that in mind as well, that when you are doing these or trying to change these behaviors, that you're actually helping to prevent other diseases. So I know we've been talking a lot about just sort of what colorectal cancer is and what are the screening methods and what we can do to prevent it. But we do also know that there is some sort of play, I would like to say, when it comes to family and genetics. And it's important to know your family history. So now I had the opportunity to present Dr. Melissa Frey, who is a gynecological oncologist and a cancer genetics researcher here at NewYork-Presbyterian Weill Cornell Medicine. Dr. Frey will now speak with us about the role of family history and genetics in colorectal cancer. Thank you.
My name is Melissa Frey. I'm a gynecologic oncologist at Weill Cornell Medicine. Thank you very much for the opportunity to speak today regarding family history, genetics, and colon cancer. In the United States, about 1% of people have a mutation that can cause cancer. A mutation is defined as a change in genetic material passed from parent to child that can cause disease. We'll begin with some definitions for hereditary cancer. Cells are the building blocks of the body. They make up all of the organs and tissues. Every cell contains DNA, the hereditary material and the code for building and maintaining cells. Sections of DNA are called genes or instructions for the cells, and many genes together form chromosomes. People inherit 2 pairs of chromosomes. 23 are maternal and 23 are paternal. Long strings of DNA, which contain genes, are stored and tightly wound into chromosomes, which reside in each of our cells in an area called the nucleus. How are genes shared in families? Let's take an example of a woman with 23 pairs of chromosomes. We'll give an example of one specific chromosome, and we'll say that she has 2 copies, a blue copy and a green copy. We know that she must have received one of each copy from her parents. So from her father, she received a blue chromosome, and from her mother, a green chromosome. If this woman then goes on to have children, each of her children will receive half of their genetic material from their mother and half from their father. Now we can imagine that this green chromosome contains a cancer-causing mutation. With genetic testing, we could determine that this came from her mother, who also shares that green chromosome. And genetic testing of her children would then also demonstrate that a son and a daughter who both carry that same genetic material also carry that cancer-causing mutation. How does this relate to familial colon cancer? Approximately 100,000 cases of colon cancer are diagnosed each year in the United States. If all individuals with a colon cancer underwent genetic testing, approximately 10% would be found to carry a mutation in their genes that increases their risk for hereditary cancer. For an example, this is a woman and she has 2 pairs of a certain chromosome. And let's say that this red chromosome contains a non-functional or mutated version of a gene, whereas the blue chromosome contains a functional gene. If she has a partner who has 2 functional copies of this gene, and they go on to have children, the children each have a risk of approximately 50-50 of inheriting that non-functional or mutated gene from their mother. And unfortunately, anyone who carries 1 copy of that mutation or non-functional gene will have an increased lifetime risk for developing colon cancer. What are the familial colon cancer syndromes? Familial adenomatous polyposis, or also called FAP, is a mutation in a gene called APC, and it increases the risk for colon cancer, with affected individuals having numerous precancerous growths in the colon starting in childhood, Unfortunately, up to 90% of people will develop colon cancer by age 45 without screening and treatment. Lynch syndrome is another colon cancer syndrome. It's caused by a mutation in one of 5 genes, MLH1, MSH2, MSH6, PMS2, or EpCAM. It's associated with colorectal tumors, but also several other cancers. Here again are the Lynch syndrome genes, and the cancers include colorectal cancer, endometrial or uterine cancer, ovarian cancer, breast cancer, gastric or stomach cancer, pancreatic cancer, prostate cancer, bladder cancer, biliary tract cancer, kidney cancer, and finally brain cancer. MUTYH-associated polyposis is another colon cancer-associated syndrome caused by a mutation in a gene called MUTYH, and it results in numerous precancerous growths in the colon. They're called adenomas, which can then progress to cancer. Finally, what if there are families that have a strong family history of colon cancer? Let's take this family, for example. A mother and 2 of her children have developed colon cancer, but we performed genetic testing for the patients and all of the relatives, and all of them are negative. There's no mutation that we can find. They don't have Lynch syndrome. They don't have APC mutations. What does that mean for the family? Well, actually, we know there are these families that have an increased incidence of colon cancer without a mutation, and relatives are still at increased risk for colon cancer. So if anyone has even a single first-degree relative with colon cancer, we know that their lifetime risk is twofold for developing colon cancer. So these are also individuals and families that we want to be very cautious with and often increase our colon cancer screening for. Why is it important to identify people with cancer-causing genetic mutations? Well, let's take the example of someone who has Lynch syndrome. If we have a person who develops a colon cancer and then undergoes genetic testing and we identify Lynch syndrome, there are many important downstream implications. First of all, treatment of that cancer. We now have personalized, individualized treatments based on sequencing of tumors. And so a patient or a person with colon cancer and Lynch syndrome might be a candidate for immunotherapy or other targeted therapies. We know that this person has an increased lifetime risk of developing another gastrointestinal cancer. So after the diagnosis of a colon cancer, we likely will have increased surveillance with colonoscopy or endoscopy to make sure that this person doesn't develop another gastrointestinal cancer. For women, we know that there's an increased risk of uterine and ovarian cancer. So we recommend screening with ultrasounds and uterine biopsies. And then for women who are not interested in future childbearing, we actually recommend a risk-reducing surgery where we remove the uterus, tubes, and ovaries to prevent a cancer from developing in these organs. Many people with Lynch syndrome also have an increased risk for pancreatic cancer, and we have pancreatic cancer screening programs now available. This is often a combination of ultrasound and MRI. And finally, there's one more important implication of identifying these syndromes that's often undervalued: cascade testing. What is a cascade? A cascade is a process whereby something, typically information or knowledge, is successively passed on. Cancer cascade testing is the process of offering relatives who are also at risk for carrying the mutation the option for genetic assessment. Cascade testing is very powerful. And let's return again to a family to show an example. If there's a woman who has colon cancer and Lynch syndrome, we know that all of her first-degree relatives, parents, siblings, children, have a 50% chance of also carrying that same mutation. So these are all relatives who should have the option for genetic testing. Let's say her parents undergo testing and we identify that her father carries the same mutation. We can then extend the testing to additional relatives of her father's siblings, her father's nieces and nephews. This is, again, additional cascade testing to identify anyone at risk. And when we find mutations in these relatives, we have the opportunity to offer cancer screening and risk-reducing surgery. How does cascade testing work in the real world? So people with colon cancer undergo genetic testing, and in most centers, this happens quite well. And if we find a mutation, we inform the person, and also that affects their treatment and their cancer screening. But where things break down is the next step, which is informing relatives, because we know that all of their relatives are going to have an increased risk for carrying this same familial syndrome. And unfortunately, in the real world, less than 30% of relatives end up undergoing testing for that syndrome. Why is it the case that so few family members complete genetic testing? Let's again look to an example. If we have a person who is diagnosed with colon cancer and found to have a syndrome like Lynch syndrome, there's a lot happening. This person has to cope with a cancer diagnosis, often prepare or recover from surgery, sometimes prepare for treatments like chemotherapy, navigate time off of work and the financial toxicity of cancer and cancer treatment, and then also consider his risk for other cancers. While navigating all of this, we're asking people to also think about cascade testing. What does that mean? Well, we tell this person that this person is responsible for contacting his relatives to discuss his new cancer diagnosis and this genetic mutation that we've just told him he carries. We're asking him to explain these complex genetics to his family members, and finally, assist his relatives in getting genetic testing. So currently, the medical system places the burden on patients and asks patients to really facilitate all of cascade testing. So it is no surprise that this is a lot to ask of people who are struggling with a new diagnosis of cancer and a mutation. In response to this, we designed a pilot project at Weill Cornell Medicine with the goal of taking the burden off of the patient and putting the responsibility on us, the medical team. We call this clinician-facilitated cascade genetic testing. How does this work? Well, we offered enrollment in this trial to any person at Weill Cornell Medicine who had a new diagnosis of a cancer-associated mutation, like an APC mutation or a Lynch syndrome mutation that could increase the lifetime risk of colon cancer. We met with these people and worked with them to determine which of their relatives would benefit from genetic testing. With approval and consent from our patients, we contacted these relatives by telephone. So instead of asking our patients to call their relatives, we offered to do this for them. And we reviewed the mutation in their family. If relatives were interested, we offered them the opportunity to undergo genetic counseling over the telephone to really go through the mutation in their family and what could be done about testing. And then for those who were interested in genetic testing, we actually allowed them to complete testing in the comfort of their own home by mailing a saliva kit to their home with a self-addressed envelope back to the testing laboratory. Finally, we called all relatives to review the counseling so that the relatives could learn about the results. They could learn about options for cancer risk reduction, so what they could do to reduce their lifetime risk of cancer. And then we also sent all of this information to the relatives' primary care doctor and treating team so that there could be good continuation of care. What did we find? Well, we know that historically, less than 30% of relatives undergo genetic testing in a cascade style of testing. With our pilot intervention, we were able to complete testing in 60% of at-risk relatives. When relatives find out that they have this cancer-causing mutation, do they act on this information? Because while we're very proud that 60% underwent testing, this only matters if it can actually help the relatives. Is this information useful? Does this prevent cancer? We called all of the relatives who participated in our study back at 2 years. And of those who had a mutation, so those who shared that same mutation as their relatives, we found that 75% had undergone a total of 36 screenings for cancer. This included breast screening because some of these mutations increase the risk of breast cancer. 18 relatives underwent breast screening. There were 9 gynecologic cancer screenings, 1 prostate cancer screening, 5 gastrointestinal cancer screenings, and 3 skin cancer or dermatologic cancer screenings. Additionally, 14% of relatives underwent 6 risk-reducing surgeries. So these are surgeries meant to decrease the risk of developing a cancer. These included what's called a bilateral salpingo-oophorectomy, removing the ovaries and fallopian tubes to prevent a cancer of the ovary or fallopian tube, a hysterectomy combined with a bilateral salpingo-oophorectomy, that's removing the uterus, tubes, and ovaries, and mastectomy, that's removing the breast to prevent a breast cancer. Additionally, we were very excited to find something called the cascade of the cascade, when we contacted relatives, we learned that 12 people reported that a total of 14 additional relatives underwent testing, and 6 of these additional relatives were found to carry the familial mutation. And that's really what we mean by a cascade. The more people who get tested, the more additional relatives we can identify and offer cancer risk reducing strategies. So again, this is called the cascade of the cascade, or the second cascade, and this is what we're hoping to achieve. So we know, compared to historical studies, our Weill Cornell medicine clinician facilitated cascade testing resulted in significantly more relatives who underwent testing, changing the rate from under 30% to 60% of relatives who are at risk. Additionally, we know that the majority of these relatives are actually acting on and hopefully benefiting from this information with cancer risk reduction strategies. Our hope and our goal is to show that cascade testing can decrease cancer incidence, cancer morbidity, and cancer mortality. In summary, many colorectal cancers are due to familial mutations. Identifying these mutations is critical for treatment of cancer, prevention of cancer, and determining the risk for relatives so they also can have prevention of cancer. At Weill Cornell Medicine, we have ongoing pilot projects that aim to help families share information about genetics and assist interested relatives in getting genetic testing with the goal of cancer prevention and early diagnosis for our patients. Thank you again for inviting me to speak today, and I look forward to answering any questions.
And thank you, Dr. Frey. I think that, listening to your presentation and just understanding the importance of us knowing our family history to have those difficult conversations is key. Additionally, just the fact that you all are doing something in terms of taking the burden off of a patient once they get cancer, when there's just a lot of information happening, is especially critical in this. So I thank you for the work that you're doing. So now we are turning over our presentation to some folks that you've seen in the community. So I'm going to ask our community voices, I call them, to turn on their cameras. So Dan Foster, Pamela Esposito-Amery, Charles Hayden, and who am I missing here? Oh, I'm so sorry, I'm missing someone. Dan Foster, I have you. Charles Hayden, Pamela Esposito-Amery, and Diane Nathaniel to turn on your cameras, please. Okay, we'll give them some time just to turn on their cameras, but in the meantime, I definitely encourage you all to put any questions that you have in the chat. I don't have any questions just yet. And as well, if you are on YouTube, to post your questions in the chat box. And you all can also take off your unmute yourselves if you would like. And I'm going to introduce our new faces now. And I'll just ask a question to each of you all. So Mr. Foster, since you already have your microphone off, Dan Foster is a resident of Brooklyn, where he lives with his wife, Joanne. He has 3 children, 4 grandchildren, and is welcoming a great grand in April. Congratulations.
Thank you.
I have your bio, but I think it's important for the audience to hear your story from your mouth, and as well as with the other speakers. So you've been involved in so much advocacy work, including the national organization Colorectal Cancer Alliance, and I know also the Walk of Hope, and that's just a little bit of a lot that you have done in terms of colorectal cancer awareness. So can you tell us a little bit about what colorectal cancer awareness means to you? Or I'm sorry, the month means to you?
Yeah, the month, what the month means to me is, get screened.
Mm-hmm.
And how fortunate I am, because I'll let everybody know I was diagnosed in 1996 with rectal cancer. So I'm soon going to be a 25-year rectal cancer survivor. So I try to tell people to get screened, how important it is for the early screening, which is 90% preventable, treatable, and beatable. And don't wait. It seems that more men don't like getting tested, than the women. And I think that's because some people that haven't been screened yet tell them things that really aren't true. The hardest part, I'm due for my colonoscopy now, the end of April again. I go every 3 years. And the hardest part is the prep. And they've come a long way with the different types of preps. I've probably had like 3 or 4 different types of preps now. So that's the most, that's the toughest part. And of course, the unknown, when you go in, you're still wondering, has anything, coming back, or, it's just that the early screening is just so important. Like I said, I never thought that I would be here now. I didn't think that I was going to live 5 years. And my cancer, went to the rectum in 96, and 1999, it metastasized to both lungs. So it's pretty rare, I believe, to live, 25 years after metastases. And I am going to say one thing. My surgeon was Dr. Warren Anker. He has since passed, and that's why I'm mentioning his name. And if it wasn't for him, I really wouldn't be here. At that time, I had a rare surgery. It was called T.E.A.L, total mesorectal excision. I believe today there's more surgeons that are performing this life-saving, surgery. It's been very, very informative. I've been listening to the whole thing. And like I said, it's 90% preventable, treatable, beatable when caught early. There's more younger people that are coming down with colorectal cancer. I'm not sure if you can hear me.
Yes, we can hear you.
Okay.
Yes, you can
No,
continue. It changed. Don't worry about that.
Changed.
Thank you.
And it's very, very important. Like the other doctors said, you catch it early when it's a polyp, they can remove it. There's no pain. You're totally sedated. It probably takes, I think mine is probably that 20 minutes, half hour. After you have that done, they actually give you your results right then and there. You talk with your gastro doctor. You have to bring somebody when you're going for a colonoscopy. And the one big thing is too, once you're diagnosed and you have to go to see a surgeon, please have somebody go with you. That's very important because you're never going to remember everything they tell you. And there's so many different treatments today than what there was 25 years ago. I had the 5-FU and leukavorian. Now they have a lot more treatments. When I was first diagnosed, they had checked 19 lymph nodes. Everything was good. So I only had the radiation, 29 treatments of radiation. When it came back in 1999, then I wound up having to do the chemo, and that was for about 6 or 7 months. And I did that I was told for a couple of people, just go on Fridays. I says, why on Friday? He says, well, you're going to feel tired, and this way it's the weekend. Family will wind up being home if you have any problems. So that worked out really well for me. And with the with the Colorectal Cancer Alliance, I've been with them from the very beginning, because when I was first diagnosed, there really wasn't any support groups. I even called the American Cancer Society, and they're the ones that gave me the Colorectal Cancer Alliance, and they're made up of survivors, caregivers. They have a program called the Buddy Program, and I'm involved with that. What they do is the type of cancer that I had, rectal cancer. If somebody else has any questions and had rectal cancer, then they can get in touch with me or anyone else that had rectal cancer. I actually spoke to somebody as far, they lived in Hawaii, and they since moved to California. And I just happened to speak to that person. It was either last week or the week before. And, it's just helping somebody, it's just so important for me to help somebody else. I don't want them to go, through the same treatments and everything else. And, I just want to give other people hope. I didn't mention, I wound up starting the Walk of Hope in 1999, where I actually wound up walking from if you live in New York, I walked from the Montauk Point Lighthouse to St. Patrick's Cathedral. So that's between 140, 150 miles in 7 days. And I called it the Walk of Hope. And, and I felt like I did the walk alone, but I wasn't. I feel that everybody that succumbed to cancer was with me. And my biggest thing is, to give everybody hope. And I hope I can do that being a 25-year survivor.
Thank you so much, Dan, for that. And thank you. We are so happy that you are here to share your story for 25 years of survivorship, to bring awareness to just the disease and to bring awareness to men as well, who may be a little bit more hesitant to get screened for colorectal cancer. So I'm actually going to turn it over to Ms. Pamela Esposito-Amery, who's the co-founder, CEO, and a board member of Tell Every Amazing Lady About Ovarian Cancer, the Louisa and McGregor Ovarian Cancer Foundation, known as T.E.A.L. It's a nonprofit foundation behind New York City's largest walk for ovarian cancer. Pamela also works to educate about ovarian cancer through T.E.A.L's community outreach program, regular speaking engagements, and presentations at health fairs. So, you're not here necessarily to talk about colorectal cancer in a sense that you are, usually your advocacy work is around ovarian cancer, but it was really important knowing that your personal history is tied to colorectal cancer. So if you can tell us a little bit more about that and what this month means to you.
Well, thank you. It reminds me that my grandfather died of colon cancer and my sister died of ovarian cancer. Therefore, my family members could be at a high risk for these cancers and other cancers. When my sister was diagnosed with ovarian cancer, her doctors actually suggested that she ask other family members if they wanted to get genetic testing done, that it might actually help her treatment in some way. So of course I said yes, if there was some way I could help her diagnosis. So my father, my sister, and myself all got genetic testing done, and we found out that we have something called Lynch Syndrome. It means that it's an increased risk for certain cancers like colon, uterine, ovarian, endometrial, and many others that were actually mentioned earlier in the program. So I wanted to kind of put out there that maybe someone listening has breast cancer in the family or colon cancer. Just know that that actually can increase the risk for even ovarian cancer. And some other cancers are connected to your genes. The good news is that colon cancer and breast cancer actually have a screening test like colonoscopy and mammogram. But ovarian cancer actually has no screening test. It has signs, it has symptoms and risk factors, but a family history is one of those risk factors, which I have, of course. I got genetic testing done way back in 2007. And since 2007, genetic testing has changed pretty dramatically. It's such an exciting time in genetics, I feel. Things are ever changing. And I was told back in 2007 that I should have a hysterectomy as soon as possible, and that there were a lot of tests that I should keep up with annually. I was in my 20s and I was definitely not ready for hysterectomy or anything else dramatic like that. And of course, I didn't have a cancer diagnosis. This was just a risk. I did, however, keep up with all of my screenings. And I actually got my genetic testing redone in 2014 because so much has changed since. And there's a lot of new panels being offered. So if someone's had genetic testing done earlier than 2007, they might want to consider actually having it redone. I actually had an additional diagnosis of something called BRIP1, which increased my risk for breast and ovarian cancer. So what do I do with all that information? Just like anybody, it could be a little overwhelming, but because I'm at high risk, I make sure I have a colonoscopy. I've not missed a colonoscopy at least every 2 years. So because of my high risk of it already in my family, and I had the genetic testing done with Lynch syndrome being the diagnosis, every 2 years is what is recommended for me. And everybody might have a different surveillance that they should talk to their doctor about. I actually have mine scheduled for next month. And colonoscopy is very important, and truly can see that I have Lynch syndrome because I've had over 10 polyps removed, and one of them I actually had to go to the hospital to have removed, and I'm under the age of 50. So if I waited until the normal 45 or 50, who knows what could have happened to me. Other surveillance that I do annually is urine cytology, skin exams, mammograms. Thankfully, there are basic screening tests for those diseases and those cancers. And recently, I finally had my total hysterectomy. Everything was removed. It took a long time for me to decide to do this, but I did it when I was ready. So I think it's important for people to know that it is an individual decision for each person. It's important for you to be informed and maybe know what the guidance is for you, especially if you have a genetic predisposition like BRCA or Lynch. But talk to your family too. And, you know, we learned about our family history, but in some cultures, and including ours, we tried asking, you know, a great grandparent or a grandparents, was their family history of ovarian cancer? And a lot of times it's talked about as, well, there was that woman's disease, or maybe it was a woman's cancer, or someone had the C word, or they didn't want to say the word cancer. So it's sometimes hard to know your family history. And genetic testing could actually be useful to learn your risk. So I highly recommend it. It's, you know, a part of my life now, and it's something that I try to encourage the rest of my family members to be proactive about. It's not for everyone, but consider all your options. It can help catch cancer earlier in some way if you're getting those screenings earlier. So work with your health professional to figure out what's right for you. And remember, even though we're still in a pandemic, it's so, so important to keep those doctor's appointments because early detection saves lives. Thank you.
Thank you so much, Pamela. And I think that, you know, you brought up an important point that I like to say, that it's important just to have the information. What you do is up to you, but, you know, you have to at least have the information so you can make an informed decision about your own health. So I know that having you deciding to get a total hysterectomy when you were ready, at least you had that information prior, and can kind of weigh the risks and benefits on an individual level instead of something happening where you have no choices out of your hands. So it's just important. That's what these webinars are for, what health education is for as well. I'm going to turn it over to Miss Diane, Nathaniel. Also, I'm surrounded by Brooklyn residents, by the way, today. I live in Queens, but everyone's from Brooklyn on this, in terms of our community voices. So Diane is married and the mother of 3 children whom she refers to as her heartbeats. Like the other speakers you just heard, Diane is a community pillar and continues to advocate for cancer patients through many initiatives, including the establishment of Beat Stage 3. So Diane, can you let us know what this month means to you?
Good evening, everyone, and kudos to my thrivers, you know, Dan and Pamela. I'm in good company. This month means to me, I am a stage 3 colon cancer thriver. So it means I'm alive. I just celebrated my 7-year cancer anniversary. I name it all just to give cancer a kick in the butt. Yeah, 7 years, 7 years. So I feel like when I celebrate and tap dance all over cancer, it can't come back. That's just my little way of celebrating. It's also, though, a reminder that the work we are all doing, informing the community and family members, extended friends at large about how important it is for screening and prevention to detect, you know, a disease that is preventable, treatable, beatable, as everyone has said here, is my life's work. I promised that if I was alive beyond my grave diagnosis, that I was going to spend the rest of my life advocating. So I didn't start in the traditional way where I had like what symptoms would look like. I mean, I was 44 when I was diagnosed, and I was diagnosed 7 years ago, back when the screening age still was 50, and I was in late stage. And I actually started with having a shoulder surgery, and they did pre-surgical testing and found that my hemoglobin was in single digits. I'll be honest, who knows what their hemoglobin is supposed to be, right? You get blood work done, and you never asked for the panel results. And then they sent me for like iron infusions for 2 weeks in order to bring the blood levels up to have the surgery. And after that, they recommended that I continue to see this hematologist. And I'll be honest, I only continued for maybe 2 to 3 months because I have such a demanding job as a guidance counselor. And then I like literally got fatigued. I had a rapid weight loss, a rapid weight gain. I was struggling with constipation, bloating, excessive gas. And so I went back to see the doctor after I had this cold for like literally a month and a half. And I switched doctors. And she said, let's do a panel with my physicians And we signed on to do like a GI exam, a EKG, all the work. And before I could do it, I had rectal bleeding. And normally I don't look, right? None of us really pay attention to what we're excreting, but we absolutely should, because when we're women and we complain about bleeding, most doctors say, oh, it's your cycle, right? They go right to you're bleeding twice because you have a cycle, or you're maybe you're premenopausal. I don't feel like when I complained about a lot of these same symptoms early on, anyone took me seriously. I felt dismissed, I felt unheard. And here we are, right 10 years later, when I complained about patient and gas and things like that, this was always synonymous with your cycle. So for any woman listening, we all know when something is not right with our bodies. I would say advocate for yourself and push a little harder and make them dig just a little bit deeper. It's not enough to just, say this is what it is. And then the rectal bleeding, normally because I don't look in the toilet, is what saved my life, because it never happened again. I thought it was my cycle. And then when my change, women, we changed, it was clear. And I was like, I know for a fact I saw blood this morning. I immediately called the GI. She got me in the same day. I had a colonoscopy that very Friday of the week. And I was awakened to know that I had adenoma. I would need major surgery. The surgery revealed stage 3. So I had 12 rounds of chemo over 8 months. Then I had a support installation. I had my cecum part of the colon removed, 14 lymph nodes, appendix. I mean, now I have long-lasting side effects from chemo, and I'm infertile, right? It's like last week was the first time I shared that, but doctors kind of dismiss it when they say, oh, you're in menopause early. No, chemo snatched my ability to have children, because I had cancer. And so if you can have all of those things be prevented for you, right? Not that I wanted any more children, but I don't have the option. For any woman or any man, thinking about having a family, a future, or even living for the family you have, it is incumbent upon you to go have this colonoscopy. It is the best sleep you're ever going to have legally, right? Because I'll admit that was a good sleep, and you don't feel a thing. You wake up, if there's a polyp, they remove it throughout the procedure, and you're good to go for the next 10 years. But if there is something there, you want it to be attended to. So I'm just going to encourage everyone to please go. Yes, the prep is not, the greatest, but we've all had some bad food. So let's take advantage of those opportunities. Sorry, I was timing myself.
We'll give you a couple more seconds, Diane. It's okay.
I wanted to make sure I didn't go over.
Thank you.
So I just want to encourage you all, just go and just think about your future. And it's very minimally invasive. And it is literally the best thing you could do for your health. Thank you.
Thank you, Diane. And every time I hear you speak, all the speakers talk, I'm just so grateful for having you all here, but be energized by all the work that you guys are doing respectively, and for your vulnerability. I know it takes a lot to share those stories, and it takes you to a place that, there may be some pain associated there. There's some unfavorable memories associated, but thank you for sharing your stories. Last but not least, I know Mr. Hayden, I think you might be having some camera trouble, so we won't be able to see you, but you're also a Brooklyn resident by way of North Carolina, if I'm not mistaken. And when we spoke about this event, you said, I want to get on and speak to people so that they understand the importance of colonoscopies. So can you tell us a little bit more about your experience and how you even started to get a colonoscopy?
Oh yeah, can you hear me?
Yes, we can.
Okay, well, my name is Charles Hayden, and I live in Crown Heights section of Brooklyn. And my story is like 5 years ago, I got my first colonoscopy. And it wasn't because I was afraid or uninsured, but I always would go get my checkup, my blood work, and I exercised and everything. So I thought I was the board of health. So I thought I didn't need one. So a dear friend of mine, she was telling me about how she going to get hers. So I thought about it, and I swam, and I was in the locker room, and the other guy in the locker room said, I won't be here the next 2 days because I'm going to get my colonoscopy. So I said, well, this person said they're going to get theirs. So I saw my physician, I said, I want to get a colonoscopy. So my PCP set me up for the colonoscopy. I had the colonoscopy done. And when they rolled me in the recovery room, they came in there with this sheet. They said, Mr. Hayden, we have some good news and bad news. I said, yes. He said, well, we found some polyps in you. I said, me? Not me. He said, yes, we were able to move the small ones, but the large one, we couldn't touch it because we don't know whether it's cancer or not. So right there, my whole thing just dropped to the floor. So I said, okay, what do I have to do? They said, well, we sampled it, we send it to the lab, and we'll let you know in 10 days whether it's cancer. So if it's cancer, it's a whole different story what we have to treat you. But if it's not, we can go in there and remove it. So like 10 days, I said, well, do it. I need any medication? No, just go live normal. So 10 days, my head was just like floating. And I went back and they said, well, good news is not cancer. But we guarantee if you don't do anything about it, 1 to 3 years, it will spread to full-blown cancer. So right away, I said, doctor, you got to take it out. It's like that. So my thing is to tell is, but now when I've gotten that colonoscopy, they'll tell them where I might be right at this moment. So my thing is to get tested. That's what saved me getting tested, you know, and I'm very grateful that I did. And that's my message, just testing. And I think the thing is, it's not that people are not afraid or unsure, they're just not aware and they think it's not important. And that's the message that we have to get out there. It's a silent disease, you know. You never know until it's too late. So that's my story, and I thank you for letting me be able to share it and people listen to me.
Thank you, Mr. Hayden. You know, again, the gem that I took away from that, or the point that I took away from that is it's important that we have in these conversations as friends, family, that we're talking about screening, because in Mr. Hayden's case, that wasn't presented to him at a routine doctor's visit. It was, you know, it was presented through his friends. And what would have happened if your friend didn't say something, or you didn't go to the Y that day and run into that person who said that they weren't going to be there for the next 2 days due to getting a colonoscopy. So encouraging everyone to have conversations with your friends, your family. Again, knowledge is power, and early detection saves lives. So we've had our physicians who spoke to us earlier waiting on the sidelines, and I just want to invite you all to turn on your cameras now for some questions, clinical questions that we may have coming in. Thank you so much, Dr. Crawford, Dr. Frey, and I think Dr. Yo, I see you there as well. Okay, so before I start, and I just want to make sure that everyone is getting their questions in. If you do have any questions, please do not hesitate to put it in the Q&A. If you are putting in the chat, we'll also take it from there, but Q&A is just easier because everyone will be able to see your questions. So before I start, I just want to say, Mr. Foster, your family from Virginia, they say hello. So I just wanted to say that. So we have a question here. I will send this question to Dr. Crawford, excuse me. So once you get your first colonoscopy, how often should you repeat it? So someone's asking if it's every 3 or every 4 years. Can you remind us of how often we should be getting screened or getting our first colonoscopy?
Sure, no problem.
After our first colonoscopy.
So I just wanted to thank, you know, Dan, Diane, Pamela, and Charles for sharing their story. I thought those were all very, very powerful. And, you know, I hope everyone was able to take, you know, important messages out from everything that they said. Now, in terms of, you know, when to repeat a colonoscopy, it all somewhat depends on the reason why you're getting a colonoscopy. So if it's just for screening and you know that there's no family history of colon cancer or colon polyps, if we perform the procedure and everything is clear, you can technically come back in 10 years, unless there is a symptom that develops between that time. So if I tell you that your colonoscopy is normal, I'll see you in 10 years. I still want you to reach out to me if you develop a change in your symptoms. And that may be you seeing blood in your stool, that may be a change in your bowel habits, that may be abdominal pain. It may be, you know, a change in your weight where you're losing weight, you know, unintentionally or unexpectedly, or anything else that seems strange or unusual. You should always just reach out to your gastroenterologist or your primary care doctor or your internist and just let them know what's going on with your health. Now, if there are polyps, you know, we have certain kinds of rules where if you have a certain number of polyps, you may need to come back sooner. That may be 7 years, 5 years, 3 years, or 1 year. And that may all depend on the number of polyps or how big those polyps are. And we can get, a little bit more specific, at the time of the procedure itself, or when we get the results back from the pathologist, because that really will dictate whether it's 1, 3, 5, or 7.
Thank you for that. And I think the person who did ask this question said that the reason may be family history. So I think that that may also have a different set of guidelines. So I'll send it back to you as well.
Correct. So if there's a family history, then we tend to bring people back every 5 years if it's a normal exam. Of course, if someone has a personal history of anything that puts them at increased risk, so Lynch syndrome, for instance, we would want to bring them back every 1 to 2 years, even if their colonoscopy was normal, just so that we know that we're not missing anything. Certain patients that have certain kinds of conditions like ulcerative colitis, they do need to have a repeat colonoscopy every 1 to 2 years. And of course, those patients that have had radiation to the gastrointestinal tract or in the pelvic or the abdominal area, we would bring back sooner, and that may be up to 5 years. There are some conditions where people may have had chemotherapy, and an oncologist may be concerned about the risk for malignancy, and that is something that we usually discuss with the oncologist on how frequently someone needs to come back for those repeat procedures.
Thank you so much. And kind of just piggyback off of that question a bit, maybe this is more so a question that I have, is just why have we seen that 10 years is the recommended time frame between colonoscopies for those who are at average risk of developing colorectal cancer? Could you speak to that, Dr. Crawford?
Sure. So we know that cancers, for the most part, usually start off as small little growths, and these growths are slow growing. So over time, just based on patients that have had colonoscopies and looking at pathology specimens from surgeries, we do know that there's a lag time. So when we schedule these intervals, it's really not to detect colon cancer, it's really to catch polyps while they're still small. And those intervals have a built-in laxity, where if you're a couple months off, you're still not at risk for finding a cancer, you're still going to be able to find one of these small lesions.
Thank
but
you.
these polyps are small growing. The key is to really catch them early.
Understood. Thank you so much. Dr. Frey, I would actually like to ask you a question now, just as it relates to family history. I know that a lot of times these conversations are uncomfortable, as Pamela said. People don't want to talk about it. They talk about the C word. And, as we have more open conversations about cancer and how it relates to our family, how do you coach your patients in a way to have these conversations with their family members if something does come back that suggests that they do have a genetic mutation that can be passed down from family member to family member?
Sure. So currently what we're doing right now is if we find a mutation, we are preparing a family letter. And so that's a letter that sort of describes the mutation and also gives the recommendation for testing in the family. And so we usually give our patients that letter, and we also kind of practice with them sort of how do you discuss this with relatives, and also what's the risk that each of your relatives have. For my patients also, because I really have an interest and a passion for Cascade Testing and educating families, I always offer to speak to the family members if the patient feels like they need help with the conversation. And I know most of our geneticists, when they do genetic testing, will offer to have family members come with their relatives when their results are disclosed, so that sort of the whole family can have group counseling. But I would also argue that I think as a medical community, we don't do a great job talking about familial cancer risk. People have studied this, and it shows that we really should spend at least 30 minutes when we meet a patient talking about family history. And on average, we spend about 2.5 minutes. So I think we really need to do better talking about family history, because we can't expect patients to be able to have these difficult conversations if we're not allotting that time with our patients.
Sorry, on mute, on Zoom, not surprising, right? So the next question that came up was just how it relates to just past diagnoses or other cancers, such as prostate cancer, and it being a grandfather who's diagnosed with prostate cancer. And now that this person is in their mid-30s and getting regular checkups with their PCP, should they also begin the recommended age of screening for colorectal cancer at 45? So I guess more so is this a question of, is there any link between that we know of between prostate cancer and colorectal cancer. So I'm not too sure. I think either one of you three is able to answer. So I will allow whoever who wants to jump in here to answer that question.
I can just start. As far as genetics go, I think our understanding of genetics is changing rapidly. And even our understanding of Lynch syndrome, you know, the realization that some families can have a lot of colon cancer, but also have a lot of breast cancer and maybe some prostate cancer is really something that is evolving as we speak. And so I think patients certainly can't keep track of this because providers can't keep track of this. The guidelines are constantly changing. I think one of the things that is positive is that we're also the technology is changing. And so right now we can use automated risk models that can kind of help us figure it out, help patients figure it out. And so really all we have to do is keep taking family histories, and we're getting the tools to help figure this out. And so I think as for a person, when they're thinking about their family history, the most important thing is just to inform the physician about what families run what cancers run in your family. And then it's really up to us to use the resources that we have now to figure out whether or not that fits into a certain syndrome.
I think Dr. Frey is right. The one other thing that I'll comment is many cancers have similar associations with toxins and environmental exposures. And so thinking about, you know, smoking obviously increases the risk of multiple cancers. So those associations with diet should also be kind of kept in light.
Thank you so much for that. And Dr. Yo, I actually have a question for you. If you can just speak a little bit more about polyps. I think that's something that we've all heard, but are all polyps precancerous, I should say? And how does that, I guess just a little bit more information about polyps in general.
Yeah, so there are multiple different kinds of polyps, and there are different underlying causes for what happens with the polyps. We talked a little bit earlier that polyps are abnormal growths. Some of them are caused from inflammation. Some of them can be caused from other kind of exposures, but some of them are precancerous. And as Dr. Crawford talked about earlier, you know, there are different amounts of time it takes different types of polyps to become cancers. And so depending on what the pathologists say after a polyp is removed, how that polyp looks will help us kind of decide what patients' longer term risks are for having more polyps or for developing a cancer.
Thank you for that information. Let's see, we have another. Okay, so another specific question just related to skin cancers and whether that's any relation to putting one at risk for colorectal cancer. I think that you touched upon that, Dr. Frey. Could you just reiterate, you know, just about the importance of gathering that family history, that information, if there's any data out there now that shows that there isn't any, that there is either, if someone does have skin cancer, if it does increase their risk of developing colorectal cancer?
I don't know of any sort of direct link between a skin and a colorectal, but I do know that in syndromes like Lynch syndrome, we do often see increased risk of some skin cancers. And, you know, I think we heard a little bit before about some of the ovarian cancer syndromes, and we know that some people who are at risk for ovarian cancer can also be at risk for colon cancer and for melanomas. And so I'd also just sort of reiterate that our understanding of these syndromes is changing rapidly. And as more people get tested and we learn more, I think we're figuring out that many of these syndromes actually span many organs and many cancer types. So I think it's important that we kind of think about any cancer in a family. And we think about, you know, why people develop cancers. It's because usually it's a problem with sort of repairing our chromosomes or repairing damage in our chromosomes. And so I think we're realizing that's a more universal problem than we realized, and not going to be limited to sort of just one organ.
Thank you. So it looks like Dr. Yo and Dr. Crawford, you still are in the office, so we definitely want to let you guys go home. And I think that is it for all the questions. And if for the audience, if you do have any more questions, feel free to reach out to me. I can drop my email in the chat, and we'll definitely get you set up with someone who can answer your questions, as I am not a clinician. So I will put that out there, but I can send it over to the appropriate person. So last but not least, I just wanted to also let you all know that, at least the audience members, that our Office of Community Outreach and Engagement with the Meyer Cancer Center, for the Meyer Cancer Center, is actually offering those free stool-based tests for community residents who are at average risk of developing colorectal cancer, so not increased risk, and there's a screening assessment that we'll do. So again, the email that I dropped in there, you can contact me for more information, and I will also follow up with and if you called me, you can call me about it, but I also follow up with email for those who have registered. So I just want to thank everyone for joining us this evening. Thank you so much to the speakers, to Dr. Yo, to Dr. Frey, to Dr. Crawford. Thank you so much. And Diane had to leave, but I want to just thank to Mr. Foster, Mr. Hayden, and Ms. Pamela Esposito-Amery. Thank you so much for sharing your stories, for taking the time out to speak about the importance of screening for colorectal cancer, for just putting the word out there. So thank you again. And I hope everyone has a good evening. If you're out, to get home safely. That's especially for you, Dr. Yo and Dr. Crawford. And thank you again. We'll hope to see you soon. Bye, everyone.
Thank you.